I'm Steve Haywood, core faculty at Magnolia. We're going to talk about shortness of breath. I think very algorithmically, so that's how we're going to start. I also like to draw, so we're going to do a little chalk talk. So first of all, when I think about shortness of breath, the first thing you have to think about is, with any patient, is this a stable patient where I can start with a H&P, a history and physical, or is this patient an extremis where I need to start with my ABCs? Emergent stabilization of an unstable patient. You'll get the gestalt when you walk into the room and you'll kind of see that patient. We're going to start by talking about this patient where we have time to do a history and physical exam. You walk into the room, they're talking, they're not in severe distress, they don't need acute resuscitation. This patient, we're going to start with a history and physical exam, but I actually like to listen to breath sounds early in my evaluation of this patient because that gives me a lot of information that's going to help me branch. Because if their breath sounds are clear, that's going to push me a lot more to diagnoses like pulmonary embolism, which will be discussed more in the chest pain section. It may push me to a non-pulmonary diagnosis, such as anemia. Anemic patients get very shortness of breath. The nurse may have just said they're short of breath. You go in there, they're tachypnic, but they're moving good air, they have good breath sounds. This actually may be a metabolic acidosis, and again, not a pulmonary problem at all. So if their breath sounds are clear, it's pushing me towards these diagnoses. If their breath sounds are abnormal, then that's pushing me more towards something going on with the lungs, such as pneumonia, such as COPD, such as a CHF exacerbation with pulmonary edema, or a diagnosis such as a pneumothorax. Perhaps they have a lung that's down. Breath sounds are going to help me differentiate these. So this is what I'm thinking about first as I'm breaking down this patient. So clear breath sounds, looking at the vital signs, because if it's a PE, I would expect them at least to be tachycardic, maybe hypoxic. If they're anemic, they may be tachycardic. Metabolic acidosis, they're likely going to be tachycardic. And then for pretty much every patient coming in with shortness of breath as their main complaint, I'm going to think about a CBC to look for anemia. I'm going to think about a basic metabolic panel, because even if they have pneumonia, they may have a lactic acidosis, some degree of metabolic acidosis, and a basic metabolic panel is going to allow me to calculate that anion gap and see if I have a gap acidosis I'm dealing with. For these patients with abnormal breath sounds, that's when I need to start working on my workup to differentiate these. A lot of that will come from your history and your physical exam. So history, we're going to ask some questions like, when did this start? Did it start suddenly out of nowhere? In that case, I'm thinking more of a PE. Did it start gradual? Has it gradually been getting worse? Is this chronic? Have you had this before? They may walk in and tell you their diagnosis. Yeah, I have really bad asthma, and this happens a lot. Is it positional or exertional? We classically think of orthopnea or shortness of breath that gets worse when you lay flat as a CHF, but that can actually happen with COPD and some other diseases. Is it exertional? Does it get worse when you go walk and exert yourself? If it doesn't, that may push you towards something like anxiety. Were there any precipitating events? What made the shortness of breath worse? Was it on exertion and then you had chest pain and then you became short of breath? It's going to push us to a cardiac cause. And then asking them their past medical history. You're likely to get the diagnosis there with your past medical history. Unfortunately, a lot of our patients have this disease. It's called COPHFD, and they're at high risk for pneumonia. So they have COPD, they have heart failure, and they're at risk for pneumonia. So you can't always get the diagnosis from your history, but take a good history. So also in your history, ask about smoking, because they may not have a history of COPD, but if they've got a 40-pack year smoking history and they're wheezing quite a bit, we can't make the diagnosis of COPD definitively, but we can assume that diagnosis for resuscitation and treatment initially if they've got an extensive smoking history. So ask about social factors as well. Next, you want to do your physical exam. So we already mentioned breath sounds. Breath sounds is going to help us quite a bit to point us into a general direction. However, there are extreme limitations of the stethoscope. It's phenomenal for detecting wheezes. However, CHF, pulmonary edema, can cause a wheeze. Pneumonia, viral pneumonia, COVID can cause external compression of the bronchioles, and it can cause a wheeze. So I want to listen to breath sounds, but breath sounds on my physical exam can really just push me towards normal or abnormal. A better way to evaluate the lungs in real time, and I consider this physical exam, is point of care ultrasound. So with point of care ultrasound, we can put the probe on the lungs If we're concerned about a pneumothorax, we can immediately say, yep, that lung's up or that lung's down. We can see B lines, which will indicate pulmonary edema. We may see a focal consolidation, indicating pneumonia, or we may see completely normal lungs, which combined with wheezing in a patient with a history of COPD will push us towards a COPD exacerbation. Other things on your physical exam, think about looking for lower extremity edema. Now, if this is acute pulmonary edema, they won't necessarily have lower extremity edema because while the left heart is failing, the right heart may not be failing yet, but look for edema. That can be helpful. You may need to do a rectal exam. If anemia is on your differential, you may need to look for melena. Look for other signs of fluid retention. So on all these patients, start with a really good history and a really good physical examination. So now we've got the history and the physical exam. We have a differential that we're working with. Now it's time to work them up. Again, even if the patient has pneumonia, even if the patient has heart failure, even if the patient has COPD, anemia may be contributing to their shortness of breath. So on my workup, I'm pretty much always checking a CBC to evaluate for anemia. Additionally, all these diagnoses can put the patient into some kind of metabolic acidosis. COPD patients can be dehydrated. You can have electrolyte derangements. I'm checking a basic metabolic panel as well. If the kidneys have shut down, I may be holding on extra fluid, which is giving me the pulmonary edema. I'm checking a basic metabolic panel as well. Pretty much on all these patients, I'm getting a chest x-ray. I've been surprised with enough unexpected pneumothoraces that if a patient comes in and says they're short of breath, I'm going to get a chest x-ray to evaluate their lungs. If they're healthy and they can walk and it's not a burden to get them to x-ray, order a 2-view. If the patient is unstable or if they can't stand up, then at that time, order a single portable view for the bedside. In addition, we may need to order a CT of the chest. PE is going to be the main reason we order CTs of the chest, and that's going to be covered in the chest pain lecture, so we're not going to talk about that here. But if the patient has a really odd pneumonia, we may get a CT of the chest to further characterize that, further evaluate that. Further lab analysis, we may end up doing a BNP. Here we do a pro-BNP at Magnolia. But if they don't carry the diagnosis of heart failure, that's when BNP is most helpful because it's say, yes, they're definitively fluid retaining, they probably have heart failure, or no, they're not. In a patient with known heart failure, it's not a great tool to trend to say they're in really bad heart failure or not as bad heart failure. It's an excellent tool for yes or no, are they in heart failure or not, consider ordering it. An acute MI can throw you into heart failure and pulmonary edema. So if I'm curious about heart failure at all, I'm also going to add on an ECG, 12-lead ECG, and a troponin to check to see if there's any acute damage causing this shortness of breath as well. The other thing that's considered many times is an ABG or a VBG. The trap you can fall into with ABGs and VBGs is don't treat the number, treat the patient. If they're distressed, resuscitate them. If they're not distressed, you have some time to work with. But your consultants will want to know what the pH is, will want to know what the PCO2 is. VBG, it correlates quite well, or if you're having trouble picking up a pulse ox and you want to know that oxygenation information, consider an ABG as well.